Hello everyone, I am Dr. Trupti Gupta, working as a consultant in the Department of Anesthesiology, Perioperative Medicine and Critical Care at AIG Hospitals. AIG Hospital is a multi-specialty hospital which is 800 bedded. We do almost 12,000 cases per annum, and we have a surgical ICU which is 66 bedded and which is handled by my department only. Me, Dr. Sunil Pandya, Dr. Kiran, and my whole department is really thankful and appreciate that AORA has given us this opportunity for this tutorial. And without any further ado, I would like to start my tutorial about the lung ultrasound. So the objective of this tutorial is to cover the topics, that is advantages, clinical indication, limitation, basics and physics of ultrasonography, approaches for lung ultrasound, normal lung ultrasound, and common clinical applications. So what are the advantages of doing lung ultrasound? It is very rapid bedside diagnostic tool, minimizes the complications related to patient's transfer, no radiation exposure, it is easily repeatable with a very low cost, small learning curve, and high sensitivity and specificity. So what are the clinical indicators of lung ultrasound? To detect the traumatic pathologies like pneumothorax, hemothorax, rib fractures, pulmonary contusion, chest wall hematomas, and as part of EFAS. To detect other pulmonary pathologies like pleural effusion, pneumonia, emphysema, pulmonary edema, ARDS, COPD, and pulmonary embolism, as well as atelectasis. Can also be used for evaluating an acute onset dyspnea and can also be used for airway management, that is to confirm the placement of the ET tube, to rule out the endobronchial intubation, to assess the diaphragmatic function, and biopsy of the pleural lesion and the peripheral lung tumors. So what are the limitations of lung ultrasound? In patients who are very obese, large thoracic dressings, and subcutaneous emphysema, it is sometimes very difficult to get an image. Lung ultrasound does not rule out pulmonary abnormalities that are not reaching the pleura, and this is dependent on an operative skill set. So starting with basics of lung ultrasound, that is physics involved here, the lung ultrasound is mainly based on interpretation of artifacts. The artifacts are formed due to scattering of the sound wave. The alveolar air and bone of thoracic cage limits the propagation of the ultrasound beam. Air is an enemy of ultrasound. So for understanding that, we should understand few basic principles of ultrasound. First one is the acoustic shadowing. This acoustic shadowing happens when the ultrasound beam hits a structure which has a very high acoustic impedance when compared to the surrounding. For example, when we put a probe on the patient's chest, what happens is that the ultrasound beam passes from the skin, the subcutaneous tissue, muscle, and hits the rib here. And then it is totally reflected back towards the probe. No beam is passed below the rib. This area thus is shown as acoustic shadowing area, that is rib shadow. This looks like an anechoic area. The second principle that is very important to understand is reverberation. Reverberation happens when the ultrasound beam is moving back and forth between the two strongly reflective area. Like for example, here we have an ultrasound probe, and this is the pleural lining, which is because of the air. So the beam comes and hit it and goes back. This will give you a pleural lining. But some of the ultrasound beam is trapped between these two reflective surfaces, and they again go and hit back and come back. So this will give another image here. This is because the ultrasound machine will assume that there is another structure at the equidistant from the previous structure, which is in the deeper depth, and that will give another image. Like this, only A1, A2, and A3 are formed. This is the basic for why we get A line in the normal lung. Now coming to the images in lung ultrasound is based on the air fluid ratio in the lung. So this picture will summarize it. The first one is a pneumothorax. We know that there is in pneumothorax, there is only air and there is no fluid. What happens is that the ultrasound beam keeps on moving back and forth because of the presence of lots of air, and we get all A lines till the greater depth with no lung sliding. Second one is the normal lung, where we have air as well as fluid. What happens is that we have a normal A line pattern followed by the lung sliding. And interstitial syndrome, here we will discuss all this in detail again, but in just telling in a short form, interstitial syndrome, here we have interlobular septa, which are dilated or increase in size because of the fluid or any fibrosis, and then because of which the ultrasound beam can pass through it and they form this reverberations again. These are known as B lines or common tail artifact. The fourth, this picture will depict the lung consolidation. What happens here is that fluid is accumulated here, and fluid is a very good friend of ultrasound beam. It will happily allow the ultrasound beam to pass through it. So what happens is that we'll be able to see the underneath lung also, and this will show us the lung. So whenever we are able to see lung in your ultrasonography, that means it is pathological. So we will get different signs like Schredt sign or tissue signs here. In this fifth pathology, that is pleural effusion, because of the presence of the fluid, we can see totally anechoic picture here. So coming to the patient position, the ergonomics is very important whenever you're performing any kind of ultrasound. So here in this case of lung ultrasonography, we can patient can be in the supine lateral decubitus or can sit erect also. Whenever we are scanning the right side of the chest, ask the patient to lift their head, right shoulder, and place it behind their head like this, so that your area of interest is opened up and there is no disturbance around it. So where do you place the ultrasound machine? So we should ideally place it on the right side of the patient. Use your right hand to scan the patient and use your left hand to manipulate the ultrasound buttons like this. So coming to probe selection, all the three different types of probe, that is curvilinear, linear, and phase array probes can be used. It depends on the what area you're looking for. So curvilinear probe, this one is a curvilinear probe. This is a low frequency probe. It has become the go-to probe for most of the clinicians. The advantage being the large footprint. So we will get a larger area of examination, and even the costophonic angles can be seen. Coming to the linear probe, whenever we feel that we need more of a superficial structures, we go for this. This operates at a very higher frequency and give a very clear resolution. This choice for rib or sternal fracture or any superficial structures. Coming to phase array transducer, there is a disadvantage of using this transducer, that it has a very tiny area of examination and we can easily miss some localized pathology. We should use this probe only when we are expecting that there is some gross or diffuse pathology. Coming to scanning technique, various techniques have been described. So the most commonly scanning technique that we use is the blue point 1 and 2, and phrenic point and the Plaps point. We'll explain each and every point in detail now. The first one is the blue point 1 and 2. Here we place our both the hands on the patient's chest like this. The upper ulnar border of the upper hand is just below the clavicle of the patient, and then the fingertips are at the midline. Then we overlap the second hand on the upper hand like this with thumbs excluded. The middle portion of the upper hand is your blue point 1. The middle portion of the lower hand is a blue point 2. So we have total 4 points for the anterior chest. Coming to the phrenic point, this is nothing but continuous intersection between the phrenic line and the mid axillary line. So phrenic line is nothing but where the diaphragm attaches to the thorax and the mid axillary line. This is the phrenic point. This will cover the lateral chest. The next one is a Plaps point. This Plaps point stands for posterior lateral alveolar pleural syndrome point. Here this is nothing but the intersection between the blue point 2 and the posterior axillary line. What happens is that here we can see the posterior structures very clearly. There's something called lateralization maneuver. Here we ask the patient to tilt little bit lateral on the opposite side so that even the minimal fluid pleural effusion can also be detected. Another technique of scanning is 8-zone protocol. This was described by Volpicelli et al. Here they have divided the hemithorax into the 4 zones by using 3 lines. One is a parasternal line, anterior axillary line, and the posterior axillary line. Between these 3 lines, we get these 4 zones in each hemithorax. So total 8 zones. There is another protocol called 12-zone protocol. So similar to the 8 zone, we have this four points in the anterior hemithorax on each side. Along with that, we have four zones at the back. On each side, we have two. This is between the paravertebral line and the posterior axillary line. These 8 and 12 zone protocol are very cumbersome, long time taking, but they give very detailed examination, whatever we want. Coming to another method called POCUS 101 method. This is more commonly followed by ICU clinicians as well as ER clinicians. Here they use points called R1, R2 and R3 on the right side of the chest, L1, L2 and L3 which is on the left side of the chest. Here we use mid-clavicular line as a landmark for R1, where R1 is on the second intercostal space on the mid-clavicular line. R2 is at the 6th and 7th intercostal space at the mid-axillary line, and whereas R3, that is at the level of posterior axillary line at the 10th and the 12th rib. So when we see R1 or L1, we are covering the anterosuperior lung field. When we are seeing R2 or L2, we are covering the lateral fields of the lung. And when we are seeing the R3 and L3, we are covering the posterior inferior field of the lung. So, coming to normal and pathological findings in lung ultrasound, Daniel A. Lichtenstein has described 10 lung signs, which are the basis for blue protocol and false protocol. So, we'll be describing each lung signs in details now. So, what is blue protocol? It is bedside ultrasound in emergency. Here, they have described various profile on which we will rule out different diseases, which I'll be discussing later. And false protocol is fluid administration limited by lung ultrasonography. Here, the lung signs are as a clinical markers for the volume of the patient. And then we can rule out the causes of shock also. So, coming to the normal lung signs, here, the first lung sign that we see in the normal patient is bat sign. So, as we can see in this picture, this is the skin, this is the subcutaneous tissue, this is a muscular layer, and these are the two ribs, 1 and 2. Here we can see that this is the white hyperechoric area, this is the pleural lining. So, we can imagine a bat here. Each rib, curvilinear rib, is nothing but the wing of the bat, and the below which is the your pleural lining. This is seen in the normal lung as described earlier. Okay, so now coming to A lines, these are, as I explained earlier also, this is nothing but the reverberations, and this is the pleural lining giving A1 and A2. So coming to lung sliding, this is again seen in the normal lung. This is because of the movement of the visceral pleura and the parietal pleura over one another, and back and forth movement. This is usually lost in pneumothorax. If lung sliding is present, that means the patient does not have pneumothorax. Okay, and there is something called lung pulsation. So these are the short sliding movements of the lung that correspond to the cardiac ejection of the blood into the pulmonary vasculature. The patient is not breathing here. The movement is because of the cardiac ejection. This can be seen in the apneic patients. So we should not get confused between the lung sliding and the lung pulsations. So whenever we put another sign is the seashore sign. Whenever I put the M mode, like this is my lung sliding sign, where I put a M mode over time. Here I can see a seashore sign. So the seashore sign is nothing but this is the skin. This is the subcutaneous tissue shown as a sky. The muscular layer is shown as the ocean. All these three layers are static, and that's why we can see as a straight line. Whereas the lower part is nothing but the lung, where there is lung sliding. So we see this grainy, sandy appearance, giving a seashore sign. Coming to pneumothorax, what happens in pneumothorax is that we see barcode sign, because from above till the end of the screen, we have no fluid, no lung tissue which is moving. There is no lung sliding. The total length of the screen is static. So we get this barcode sign that is also known as stratosphere sign. There's something called a lung point. So whenever a normal lung is meeting the pneumothorax part of the lung, this point is called lung point. The presence of lung point is seen in the pneumothorax, but in cases of complete pneumothorax, the lung point will be absent. We should keep this in mind. So just to summarize, in case of normal lung, we have no motion of the chest wall as well as so this gives a pattern of the wave, and in pneumothorax there is no movement giving a pattern of the wave. But in the normal lung, the lower part, the deeper part is having the lung sliding, so we have a motion and this gives a appearance of the grainy beach. Whereas in pneumothorax, the lower part is also not moving, there is no motion of the lung, so we get this again this uh, lines pattern only. So this is seashore sign, this is barcode or stratosphere sign. Now coming to interstitial syndrome, here we have air fluid ratio is seen, and just to understand this, first we should understand what is the alveolar unit. So basic anatomy is very important here. It is the smallest unit of lung. It is about 1 to 2 centimeters in size. It contains terminal bronchiole and the pulmonary artery, whereas the pulmonary veins and the lymphatics are seen in the interlobar septae. So what happens is that during the interstitial syndrome, this septae gets widened. There'll be deposition of fluid or any other fibrotic material here, and they'll be widening here. So because of this widening, the ultrasound beams keeps on moving back and forth in the interlobular septic, giving rise to this artifact called comet tail artifacts, also known as B lines. So to consider a line, B line, there are few criteria that are to be met. First, it should be a hyperechoic artifact. It should be arising from the pleural lining. It is well defined and laser-like. There is no fading out. It obliterates or erases the A line and moves along with the lung sliding. There are few lines which can be confused as a B line. So first one is the Z line. The Z line arises this one. So the Z line arises from the pleura, okay, and it does not reach to the bottom of the screen. You can see it has faded out here only. And the other one is the E line. These are similar to the B lines, but they arise from above the pleura. This is an example of subcutaneous emphysema. In there, you get the line starting above the pleura. Another line is described that is non A line or non B line called O line. Here there are no horizontal artifacts, no vertical artifacts are seen. So, but then this is not a much clinical importance. If you do a slight movement of the probe, you may get a A line. So the pattern should be considered as having a same meaning as of a A line. So there are some conditions like physiologically also we may have rare B lines like 1 or 2 B lines. These are usually seen in the dependent area of the lung, that is the last two intercostal space. This is not interstitial syndrome. We should understand this thing. And but when you say that this patient is having interstitial syndrome, when we have 3 or more B lines, that is lung rockets between the one single rib space, this is very significant finding. So, what are the clinical significance of B line? Hemodynamical pulmonary edema or inflammatory pulmonary edema or chronic inflammatory disease, all these can cause B line formation. So, what happens is as the lung water increases, the amount and the density of B line also increases. And as we all know, first the fluid will start accumulating in the perivascular area, followed by interlobular septa, and then they will enter the alveolar area and cause alveolar consolidation. So there are two different types of B line that have been described, that is B7 and B3. So what is B7? Here the B lines are little more apart, that is 6 to 7 centimeters apart, and they represent the initial stages of the disease, that is the interlobular thickening. Whereas B3, here the B lines are more nearer, they are only 3 mm apart, and this represents the ground glass changes. So this is an example of B7 line. This is an example of B3 line where you can see the distance is very much reduced, and this is an example of the confluent B line. Here there is hardly any differentiation of the B line. That means this is a severe pathological lung. The next pathology that we'll be covering is the lung consolidation. So as we all know here, because the air is totally removed with the fluid and we can see all the lung beams passing, we'll be able to see the now lung tissue. Ultrasound beams are passing. Now we are able to see the lung tissue. So here in this case, we can see two different signs. This is a shed sign. Here, this shed sign, there is a hyperechoic structures just pale underneath the pleura. This is nothing but the shed sign. They're like shredded. They're also known as fractal sign. Okay, this is a tissue-like sign. This is seen in the later stages of pneumonia or later stages of consolidation, where the lung, we can see here, this is the liver, this is the diaphragm, and the lung is almost looking like your liver. So it's also known as hepatization of the lung. So this is a severe form. In this, again, we have this is because of the air bronchogram. These air bronchograms can be two types, static or dynamic. So in this static air bronchograms, they are hyperechoic, there are air bubbles trapped, and they are isolated from the airway, our airway. They do not move with the respiration, and same appearance throughout the cycle is seen in static air bronchograms. Whereas in dynamic air bronchogram, there is a communication between the hyperechoic areas what we are seeing and the airway, and they move with the respiration towards the periphery. The last pathology that we'll be covering is the pleural effusion. So, pleural effusion is very easily identifiable on the lung ultrasound. We have many signs described for pleural effusion. We'll be going through each one in detail now. The first one is a spine sign. Usually, because of the presence of the lung and the air inside it, we will not be able to see spine, thoracic spine for any patient. But if the patient is having fluid, we can easily see the thoracic vertebrae here. This is the spine shadow, or that is spine sign. The second one is a jellyfish sign. This is nothing but this is the atelectatic lung, which is like looking like a tentacle of a jellyfish, and this will be moving with every breath of the patient, and this is the pleural effusion. The next one is a quad sign. The pleural effusion is an anechoic appearance. Here we draw four lines like a quadrangle, and this will delineate the pleural line, the rib shadows, and the lung line, and this is known as the quad sign. When we put M mode on time for any pleural effusion, we will be able to see a sinusoid sign. This is like a sine wave. This is because of the movement of visceral pleura and the parietal pleura against each other whenever the patient is breathing. The next sign that is described for pleural effusion is a plankton sign. This is usually seen in the exudative pleural effusion where there is debris, and we can see that in this picture also you can see this debris movement with every breath of the patient. It's plankton sign. The next one is a hematocrit sign. This is seen in the hemothorax patients where the RBCs settle down and they form a consolidated, small consolidation, which is not that hyperechoic, but the upper area is anechoic and the lower is comparatively little more echoic. This is called hematocrit sign. So lung ultrasound is never completed without the examination of the diaphragm. Here we should always identify three structures. As we can see here, this is the liver, this is the diaphragm, and this is the lung. I have put the M mode on the diaphragm, and now I'm seeing the inspiratory amplitude of the patient. So what happens is that normal inspiratory amplitude is 10 mm to 20 mm. If the patient's inspiratory amplitude is less than 5 mm, it is pathological. So various profiles are described, like we know A profile by now. A prime profile is nothing but A lines with no lung sliding, and there's we know B profile, but B prime profile is nothing but B lines with no lung sliding. There's another profile described that is called nude profile. Here there is A profile with no DVT or no PLAPS point positive. And AB profile, which means that unilaterally the patient is having the B lines and other side the patient is having normal A lines. This is usually seen in pneumonia. And C profile, this is nothing but like anterior consolidations. This can be in many numbers or any size also. So this is the a chart a flow chart which is very useful in ruling out various common diseases that affects the lung. So this is described in the blue protocol. So what happens is, first we will examine the upper and the lower blue protocol. We check for the lung sliding. If the lung sliding is present and the patient is having B profile, that means the patient is having pulmonary edema. With sliding present and the patient is having A profile, we have to rule out the presence of any DVT. If the DVT has been ruled out, then we have to go and look for the PLAPS point. If the PLAPS point is positive, that means the patient is having pneumonia, and the PLAPS point is negative, that means COPD or asthma. If with A profile and lung sliding and the patient is having positive DVT examination, that means we have to go for pulmonary embolism ruling out. And if the lung sliding is totally abolished, that means with the A profile and abolished lung sliding, that is A prime, then along with lung point, that is pneumothorax. And without that, if there is no lung point at all, that means we have to go for other diagnostic modalities like CT scan and all. If the patient is having lung sliding with no lung sliding with B profile, that means the patient is having pneumonia. And as I described earlier, A by B or C profile is indicative of pneumonia. Today we will be demonstrating the lung ultrasonography, how we do in our ICU regularly. It's a part of POCUS which we do regularly here. We follow the Blues protocol here. Blue protocol stands for bedside lung ultrasound in emergency. Here we follow 2 points. As you can see here, we recognize 2 points first, that is blue point 1 and blue point 2. Okay, this is formed by placing the 2 hands like this. The ulnar border of the upper hand is just below the clavicle and the tips are near the sternum. This is my blue point 1 and this is blue point 2. When we, there's another point called PLAPS point. Okay, when we draw a line perpendicular from the blue point 2, which is intersecting the posterior axillary line, that point is called PLAPS point, that is posterior lateral alveolar pleural syndrome point. Okay, so these points are used for scanning the lung. Okay, so let's start scanning the lung. I'm using the linear probe, which is a high frequency probe. I'm putting it at the blue point 1. As you all can see, the first sign is the bad sign. This is the classical bad sign. As you can see here, this is the skin, subcutaneous tissue, muscle layer, and this white hyperechoic line is the pleural line. Okay, and these are the 2 ribs with the shadows. As you can imagine here, this is the bat. This is how the bat is formed. That is called bat sign. So the another sign that we see in the normal lung is the A profile, that is the A line. So as you can see here, this is skin, subcutaneous tissue, muscular layer, and this hyperechoic layer is the pleural line. So just below that, equidistant from the skin, we can see one more hyperechoic line, another hyperechoic line. These are the reverberation of the pleural line. That is the A profile, which is very normal in a normal lung. It's very normal. So the second sign that we see normal in the normal lung is the seashore sign. For this, we see the pleural line, put an M mode like this, and on the M mode on the timeline, this is a typical seashore pattern. The upper portion of the chest, that is the skin, the subcutaneous tissue and the muscular area being more static, gives a picture of a sea, whereas the part which is a more dynamic part, that is the lung part, gives a grainy appearance. This is the shore part. So this is the seashore sign. Examination of the lung is not completed until you have examined the diaphragm also. So we have to see the diaphragm. First, let's see how you identify the diaphragm. We use a curvilinear probe, which is a low frequency probe. The 3 main structures that we need to identify here are the kidney, spleen, as I'm doing the left side of the patient, left abdominal side, and this is the lung. And this white shiny echoic structure is the diaphragm. This is my spleen and this is the lung. I put the M mode on time. Now I'm going to measure the inspiratory amplitude. So I'm freezing it. This is the diaphragm which is moving with time. Here I'll measure the inspiratory amplitude. Usually the inspiratory amplitude is more than 10 to 20 mm in a normal individual. If it is less than 5 mm, it is pathological. Thank you.